Again, we have a quiz question, if we can put up that slide. So according to the Japan Esophageal Society simplified classification for superficial esophageal squamous cell cancer type B3 IPCL pattern predicts low grade, high grade, T1A, T1B, or inflammation. So if you have registered with your email address, the first one who's got the right answer will win 10 GIEQs coins, which can later be used to buy content on the GIEQs Online.
Then you go closer up, you take the best endoscope you have. If image characterization is your goal, you clean gently, you take an overview, and you use the maximum magnification available on your endoscope to analyze the surface pattern. That is starting with a first impression. So you freeze the image, you look from afar, you interrogate the image. Here, there's something very clear, extra red going on here, kind of a punched out area, demarcation zone. Here, there's for sure something going on and a demarcated area going on here. The question is it cancer or not? Here are some features that might suggest in the upper GI tract that it might be cancer: extra redness, fold deformation, depression, spontaneous bleeding. And in this case, there was a squamous cancer within this area of abnormality. Into the muscularis mucosa, moderately differentiated, lymphovascular negative, removed completely with endoscopic resection. So, okay, this is what you can achieve with high quality imaging. But I recognize, of course, that this degree of imaging, not everybody has access to. And this is a very nice conversation that was had earlier in the live session about what actually are we striving to achieve. And of course, the great point was made that if there is something abnormal or you expect something abnormal, you should strive for excellence. And we can get there. We can get there with the latest generation of endoscopic imaging and with the right degree of patient sedation.
In the meantime, I've demonstrated you how to clip. I don't want to use too much of a time, but you've seen that I've rotated the clip myself as well, because this particular clip allows you to rotate yourself with your hands, with your two fingers. So we've adjusted the position. We desufflated to let the tissue get in, and despite having a tiny clip, I think that we clipped it thoroughly. I'm not so afraid of having a hyperplastic reaction around as Pradip is, because I know that it may happen, and I know that it wouldn't bother this patient. And obviously, I'm much more if the patient is young, if the lesion is located in the antrum, and so on. And then we have to go with Emily really nicely. So whenever you clip anything, you have to ask your nurse to close it gently and slowly. You never, even in a situation of bleeding, you never shoot it really rapidly. So you have to be calm, you have to communicate well, look into eyes, and close it.
And while we're on to that, there's two more questions from the virtual audience while we're watching you, Michael. Finish this. Question: do you use adrenaline in your lift? Maybe we can give that to Pradeep while you're doing this, Michael. Pradeep, do you use adrenaline in the lift for your resections like this? And if you do, how much?
Nice. Yeah, invariably we would use adrenaline. I think it makes adrenaline, I'm not sure how much it helps the resection, but it helps the endoscopist because it blanches. You don't immediately see a big bleed. When the bleed starts, it's a bit slow. So I think, and we're used to it. So that's the reason we use very small dose, about 1 ml or 1 in 10,000 in 500 ml of gel effusion. But you can easily do without adrenaline. It's just a matter of your practice.
And another question
too. You're afraid to miss bleeding if you use adrenaline that you will not coagulate those vessels.
It's a very good point about if you use adrenaline that prevents immediate bleeding, will you get delayed bleeding because you missed? If you're using adrenaline, as soon as you do resection, what we do is a water agitation of the base.
Yes.
So you use your water jet and fire water jet briskly on the resection base. If there is a vessel, it will start bleeding at you.
Okay.
So if your agitation test is negative, you don't need to worry.